Today, guys, I'm going to be talking about the therapeutic procedure of nasogastric insertion and the nursing management for complications of enteral nutrition and parental nutrition. First, I'm going to start off with the therapeutic procedure of nasogastric insertion. I'm going to start off with describing the procedure. First, you want to um, review the doctor's orders to make sure you know that this is what he's ordering for this specific patient. Then you want to review the history of the patient and review to see if patient has had any nosebleeds, polyps, or any history of facial fractures. Sorry. Next, you're gonna gather your materials. You're gonna need a stethoscope, tongue blade, pen light, tape, a 60 ml Luer lock syringe. You're gonna need um, clean gloves, pH indicator, and suction equipment. After you gather your materials, head to the patient's room, identify yourself, identify the patient using the two patient identifier, wash your hands, and then proceed to ask questions and assess the knowledge of the patient of the procedure that you're getting ready to perform, and ask if the patient has any questions. From that point, that's when you would examine the patient's abdomen. You want to inspect, auscultate, palpate, and then percuss to make sure you hear bowel sounds, you don't have any abdominal distension or anything to cause reason to not um, use the nasogastric tubing. Also, you then want to inspect the patient's nares to make sure you don't see any polyps, obstruction, any type. Make sure that the nares are patent. Then from that point, you want to put the towel across the patient's chest, and then begin take the tube and then begin to measure the tube from the tip of the nose here into the pin into the earlobe, and then from the earlobe into the xiphoid process. And once you do that, you want to mark where your ending point, because that's where you want to stop when you begin your insertion. And then from that point, that's when you're going to prepare your field. Remove those gloves, wash your hands again, and put on a new set of gloves as you begin to prepare your tape. Put the tip of the tube into the lubricant, and then explain the procedure to the patient to let them know that you're going to be inserting the tube into the nasal cavity and down to the nasal pharynx. And you're going to give them a cup of water and let them know, once you begin to swallow that, to drink the water of to help with the passage of the tubing. And so from that point, that's when you're going to insert the tube. You're going to insert the tube into the nostril to the back of the throat, and have the patient flex their head forward, flex their head towards their chest as the tube is passed through, and have them take sips of water to swallow to help the passing of the tube. And once you get to the point of where you measured on the tube, that's when you will stop and secure um, the tube to your nose using the tape that you've used. And from that point, that's when you take your 60 ml Luer lock and um, get some gastric content and measure the pH. The pH needs to be um, five, less than five, and then that's when you will further secure the tubing to the nose to make sure that it's in place, to make sure that it's not blocking anything, it's not causing pressure, and then you would want to clip the rest of the tubing to the patient's gown. And after that, clean up everything you've done, remove your gloves, and ask the patient if they have any questions, and then send them off to obtain an x-ray to verify the placement, so that way you can get a accurate placement. And that's the description. That's the description of procedure for inserting of a nasogastric tube. Next is the indications for having to have an nasogastric tubing, which could be gastric decompression. You can have cancer of the upper GI. You can be comatose, GI disorders. You can be critically ill. And the outcomes, we want for our patient is to minimize the hypermetabolic response to trauma and decrease hospital mortality and maintain intestinal structure and function of the GI, and also to provide fluids, electrolytes, and nutritional support and minimize aspirations for the patient. There are potential complications. The biggest one is aspiration. Aspiration of the patient. That's why we want to keep them sitting up in a semi-Fowler's position. Also, dislodging of the tube is a potential complication. Patients sometimes can pull on it or move the wrong way, and the tube can maybe become dislodged. Tube patency sometimes you may have some obstruction, so we need to make sure that we're flushing the tubing to maintain a patented tube. Also, some abdominal distension, diarrhea, nausea, and vomiting are also potential complications of having a NG tube. Nursing interventions, we're going to inspect the nares after insertion, observe for any difficulty breathing, coughing, gagging. We're going to make sure we auscultate the lung sounds and check routinely for the site that is marked on the tubing to make sure that the tubing is still in place. We also need to check the pH of the gastric content and make sure we check our tubes for any leakage, blocks, or kinks, and we need to maintain oral care and keep the patient's nose clean and their lips moisturized with the patient. And that with what all I just explained, I just explained the procedure, the intra procedure, and the post procedure. Now I'm going to move on to the nursing management for enteral nutrition for the complications. Nursing management for aspiration for enteral nutrition. We're going to check the placement. We're going to check residuals every 4 to 6 hours. We're going to hold feedings per protocol, and we're going to make sure we continue to keep the head of the bed elevated. Also perform oral suctioning. Nursing management for diarrhea, if our patient does have diarrhea, we would slow the rate of feeding, watch for contaminated formulas, change to continuous feedings if we need to, and check the medications that the patient may or may not be receiving to see if that's a side effect of meds that our patient may be receiving. Also, another complication is dehydration, and so with dehydration, we need to check the rate of feedings that they're getting, or the fluid that they're getting, the fluid and the formula that they're receiving. We need to check for high protein content. We may need to increase intake of fluids, and we need to check the patient's blood glucose. For constipation, we need to increase the patient's fluid intake. We may need to change formula or increase fiber. We may need to give a laxative, and we need to encourage ambulation if the patient is able to ambulate. And so those are the nursing management for enteral nutrition. And so the nursing management for the parenteral nutrition, starting with infection, the patient must have a filter. With lipids, the bag and the tubing and the filter changes every 24 hours. With amino acids and dextrose, the bag filter is changed every 24 hours and the tubing is changed every 72 hours. We use sterile procedure when changing the central line every 72 hours, and we monitor for signs and symptoms of infection and monitor vital signs every 4 to 8 hours. Also, the patient may experience hyperglycemia, and for that, we need to check blood glucose every 4 to 6 hours and maintain the blood glucose in range from 140 to 180, and it's expected when given TPN. That's an expected finding. Also, may experience some hypoglycemia if the bag empties. So to prevent hypoglycemia, we want to make sure that we keep a bag of dextrose on bedside table, 5 to 20% of dextrose. That way we don't experience hypoglycemia. And so, other nursing management for parental nutrition complication is to maintain patient safety. Um, Before starting the parental nutrition, we want to check label and ingredients and solutions to make sure that they match what the healthcare provider has ordered. And have another RN verify the infusion pump settings before beginning the parental nutrition, and check the solution for leaks, color changes, particle matter, clarity, and fat emulsions, cracking, and if present, return to the pharmacy. And so, and lastly, for the nursing management for parental nutrition complications, we want to maintain parental infusions. We want to follow proper aseptic techniques to reduce the risk for infection. Use a micron filter with parental solutions not containing emulsions. And there's different size filters. The filter we will use that doesn't contain emulsions is 0.22, and the other one is 1.2 if the solution contains fat emulsions. We want to change filters and IV tubing with each new parental nutrition container or every 24 hours, and we do not draw blood from a dedicated parental nutrition line unless absolutely necessary. And we also want to control the rate of confusion. Thank you for listening to me today. I'm sorry for the hiccups and the little mistakes in the video, but thanks. See you next time.